Hi everyone, it is my pleasure to join this WFUMB-EFSUMB Student Webinar, and I will talk about ultrasound characterization of solid renal tumors. I'm Seung H. Kim, Professor Emeritus of Radiology, Seoul National University Hospital, and the Director of K-Radiology Clinic. And I'm the immediate past president of WFUMB. Let's think about how we can approach solid-looking renal masses practically with ultrasound. I think the first thing we need to do is to differentiate between true mass and pseudomass, then between cystic mass and solid mass. And if it is a solid renal mass in an adult, it will be most likely a renal cell carcinoma. But always we need to think about other solid renal tumors that may be characterized with ultrasound. And ultrasound is especially useful in chronic kidney disease patients, and always take advantage of unique real-time capability of ultrasound. So the first question we need to answer is whether it is a true mass or a pseudomass. Here are two similar solid-looking masses in two different patients. One is a true tumor, renal cell carcinoma, and the other is a pseudotumor. But it is difficult to tell which one is which with the grayscale ultrasound only. However, with the color Doppler ultrasound, which is one of the unique ultrasound capabilities, we may tell which one is which because two masses have different vessel patterns. The upper one have vessels running through the mass, while the lower one has vessels sweeping around the mass. And we may say upper mass is more likely a pseudomass, probably prominent column bulletin, and the low mass is a true mass in an adult, so most likely renal cell carcinoma. And these are CT findings confirming the upper pseudomass and lower true mass. So the vessel patterns at color Doppler ultrasound are useful ultrasound clues to distinguish between true tumor and pseudotumor. And the vessels running through the solid-looking mass-like lesion indicate the high possibility of pseudotumor. But always remember, if there are questions, we need a CT scan to confirm. These three different cases are all pseudotumors, prominent columns of bulletin. Now here's a solid-looking, slightly hypoechoic mass, which has vessel pattern at color and power Doppler ultrasound. Which pattern do you think this mass has? Yes, probably you may recognize this is a true tumor pattern, and it was a renal cell carcinoma. Again, you may easily notice that the left-sided mass is a pseudomass, column of bulletin, with vessels running through the lesion, and the right side mass is true mass, renal cell carcinoma, with the vessels sweeping around the mass. The next question we need to answer is whether the lesion is cystic or solid. Usually simple renal cysts are easy to characterize by its round or oval shape, sharp margin, absent internal echoes, and posterior sonic enhancement. If any of these findings are different from the characteristics of simple cysts, we need to suspect the possibility of solid masses. Here are two masses in the same kidney. This blue arrowed, well-marginated round mass with posterior sonic enhancement is probably a cyst. This yellow arrow, the bigger mass, is also round and well-marginated, and also has posterior sonic enhancement and edgy shadowing, and has slightly heterogeneous internal echoes, and we need further characterization. Doppler ultrasound is the easiest way, and this power Doppler ultrasound well shows this is an avascular cyst, and this is a hypervascular solid mass, a renal cell carcinoma. Once again, a solid mass in an adult is most likely a renal cell carcinoma. When a mass is large, it is easy to characterize. But if a mass is small, it may not be easy. Here is a very small isoechoic mass, and it is probably too small to characterize with grayscale ultrasound only. But with Doppler ultrasound, it is easy to say that it is a small solid mass with some tumor vascularity, and so most likely a renal cell carcinoma. And CT well shows early strong peripheral enhancement and early washout. So most likely a clear cell renal cell carcinoma, which was confirmed as surgery and pathology. Here's another example of small clear cell renal cell carcinoma showing value of Doppler ultrasound that shows similar peripheral vessels and similar peripheral strong enhancement as CT. And again, it was a small clear cell renal cell carcinoma. Sometimes the renal mass has an intermediate appearance between a solid and cystic mass. And here's an example case that shows central cystic portion and the solid looking periphery. If a mixed cystic and solid mass like this case, the flow signals in the solid looking part are important. If there are flow signals, it indicates a malignant lesion. And if there are no flow signals, it is more likely a benign lesion. In this case, there are prominent flow signals in the peripheral solid-looking areas, and it was a small clear cell renal cell carcinoma with mixed solid and cystic components. Now let's think about the subtypes of renal cell carcinoma. Renal cell carcinoma is a heterogeneous disease with multiple subtypes that vary in histopathologic features and clinical behaviors. Three common subtypes are clear cell, most common and more than 70%, and the second papillary, and the third chromophobe subtypes. They have different prognosis, with papillary and chromophobe types better than clear cell type. They have different ultrasound features, and therefore we may suggest renal cell carcinoma subtype based on ultrasound findings. Clear cell renal cell carcinoma usually has heterogeneous and hypervascular appearance, while papillary renal cell carcinoma has homogeneous and hypovascular appearance, and the chromophobe type renal cell carcinoma has ultrasound features between clear cell and papillary types. This is an example of clear cell renal cell carcinoma that has heterogeneous echo and hypervascularity at Doppler ultrasound and early strong enhancement at CT. And this is an example of papillary renal cell carcinoma that has homogeneous hyperechogenicity and hypervascular appearance at ultrasound. The papillary architecture of the tumor causes this homogeneous hyperechogenicity. And this is an example of chromophore renal cell carcinoma that has intermediate vascularity at Doppler ultrasound and intermediate enhancement at CT. A solid mass in an adult is most likely a renal cell carcinoma, but it is known that about 20% of small renal masses removed are benign, and about 60% are indolent cancers, and only 20% are potentially aggressive tumors. Therefore, it is important to characterize small renal masses before surgical removal. The most common benign tumors of the kidney confused with renal cell carcinoma are angiomyolipomas. Angiomyolipomas are typically hyperechoic, usually single, but sometimes multiple. The echogenicity of the typical angiomyolipoma is usually higher than the renal sinus echoes, like these lesions. Here's another angiomyolipoma that has an echogenicity similar to or slightly higher than the renal sinus echo, and typically shows gross fatty attenuation at CT. Even when the gross fatty component is not evident at CT, hyperechogenicity of the mass may suggest angiomyolipoma, like this case in the lower row. It is said that about 1/3 to 1/2 of the small renal cell carcinomas are hyperechoic. Therefore, we should be careful in differentiating between a small hyperechoic renal cell carcinoma and angiomyolipoma. The uppercase is an angiomyolipoma, and the low mass is a hyperechoic renal cell carcinoma. They look quite similar, but the presence of posterior sonic attenuation in the upper mass may suggest angiomyolipoma rather than renal cell carcinoma. Compared with renal cell carcinomas, angiomyolipomas are usually more hyperechoic and have posterior sonic attenuation, while the small hyperechoic renal cell carcinomas are less hyperechoic than angiomyolipomas and often have a peripheral hypoechoic rim and intratumoral cysts. Another example showing different ultrasound features of angiomyolipoma and renal cell carcinoma. Two different renal masses of similar size and similar hyperechogenicity, but the difference is this left-sided mass shows strong posterior sonic attenuation. This left-sided mass is an angiomyolipoma, and this right-sided mass is a renal cell carcinoma. Doppler ultrasound is also useful in characterizing questionable cases between angiomyolipomas and renal cell carcinomas, because angiomyolipomas usually show absent or just scanty amount of motor flow signals in the mass, while renal cell carcinomas usually show prominent intratumoral vessels. These three different cases in the upper row are angiomyolipomas with absent or just mottled flow signals, while these three masses in the lower row are renal cell carcinomas showing more prominent linear tumor vessels. You may notice different Doppler flow patterns in between angiomyolipomas and renal cell carcinomas. Next thing I want to mention is that the ultrasound is especially useful in chronic kidney disease patients. The most common mass-like lesion in chronic kidney disease patients are pseudotumors caused by focal hypertrophy between atrophic parenchyma. This is an example, and there's a hypoechoic mass-like lesion in a small atrophic kidney, and Doppler ultrasound does not show hypervascularity, and the CT shows focally bulging parenchyma with a similar degree of enhancement with the other parts of the renal parenchyma. So this is a case of pseudotumor due to focal hypertrophy in a CKD patients. This CKD patient has a similar hypoechoic mass-like lesion, but this mass shows marked hypervascularity at Doppler ultrasound, and the CT well shows the enhancing mass, which is the clear cell type renal cell carcinoma. In chronic kidney disease patients with suspicious solid renal masses, characterization using spectral Doppler pattern is very useful technique. CKD parenchyma usually shows high resistant flow spectra, but renal cell carcinomas usually show lower resistant patterns due to deficient tunica media of arterial wall of the tumor vessels. This is a hypervascular clear cell renal cell carcinoma with low resistant spectral pattern, and this is a microscopic image of the arterial wall of this tumor, which shows a deficient tunica media layer, and this is a microscopic image of a normal arterial wall for comparison. Here's a mass-like lesion with slight hypervascularity in a CKD patient, and this upper spectral Doppler is from the mass-like lesion, and the lower spectral Doppler is with a high resistant pattern is from the renal parenchyma. Those two spectral patterns are quite different, and this difference may suggest a true renal tumor rather than focal hypertrophy, and this mass was a true tumor, papillary renal cell carcinoma. Another similar example showing different spectral Doppler patterns in a CKD patient with a clear cell renal cell carcinoma. The last thing I want to mention is that the ultrasound has its unique real-time capability, and we may use this in evaluating a large renal cell carcinoma for accurate preoperative staging. When you see a kidney moving with respiration, you may notice the sliding of the kidney with surrounding structures. These are kidney and perineal fat moving together, and these are abdominal wall muscles, and this echogenic structure is the colon moving differently from the kidney and the perineal fat. Some Korean colleagues reported that this sliding sign is useful in localization of the mass origin, and it is also useful in detecting adhesion or invasion of surrounding organs in patients with large renal cell carcinomas. I will show you two such cases. Here's a large renal cell carcinoma in the left kidney, SCT, and descending colon may be involved by the tumor. The real-time ultrasound shows that the renal mass and the descending colon move together with respiration, so no sliding, indicating invasion of the colon, which was confirmed at surgery. Another case of a large renal cell carcinoma in the left kidney, and the descending colon is also close to the renal mass. And real-time ultrasound shows different movements of the renal mass and the echogenic descending colon. So positive sliding sign indicating no invasion or adhesion, and there was no problem at surgery. This real-time sliding sign is a very simple observation, but can provide very important preoperative information to the neurosurgeon. This is the summary of this talk on the practical ultrasound approach to solid renal masses. First, start with differentiating between true mass and pseudomass, then between cystic and solid mass. Although a solid mass in an adult is most likely renal cell carcinoma, please keep in mind that other solid renal tumors, such as angiomyolipomas, may be characterized with ultrasound. And ultrasound is especially useful in patients with chronic kidney disease. And finally, try to use unique real-time capability in evaluating large solid renal masses. If you have any questions or comments, please email me, and you may see related talks on my website, www.k-radiology.com. Thank you for joining this talk.